This is LiveWell Talk on dual chamber leadless pacemaker. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. St. Luke's cardiologist, Talha Farid, is the first in Cedar Rapids to be trained and successfully implant a dual chamber leadless pacemaker, referred to as the AVEIR DR, and we'll find out what that means, which is the world's first dual chamber leadless pacemaker system. Dr. Farid joins me today on today's episode to discuss this, and welcome back.
Thanks very much.
I think you're approaching the most frequent guest. You're like this is like fourth or fifth, so that's pretty cool. You can be the guest host if I'm not here. Now, despite being clumsy with describing this in the opening, tell us what is this leadless pacemaker? I'm really excited about this.
So, the traditional pacemaker, has been around for decades. You have to make an incision, then there are a couple of wires that go to the heart through the vein, and then the device goes under the skin. What the leadless pacemaker is, it's a small device that has everything in it, and it goes directly in the heart. So there's no cutting, there's no incision, there are no wires. So it's completely leadless, wireless. So there are no leads, there are no pockets. So that's essentially leadless pacemaker is.
Wow. So is it Bluetooth? I mean, it can be programmed.
When leadless pacemaker came out, they were just one device, essentially. It would go into the RV, it will just pace, but it won't have synchrony like a dual chamber pacemaker. So it won't have atrial to ventricular synchrony. So that was the limitation that we had with the initial leadless pacemakers. But now we have this dual chamber device where they're actually essentially two devices. One goes in the atrium, the other one goes in the ventricle. They talk to each other, and the algorithm and how they do it is kind of proprietary by the manufacturers.
Wow.
They don't tell you, but they communicate with each other beat to beat. So they're sending and receiving information.
So, wow. How does it stay in the cardiac chambers?
So they're depending on the manufacturer, right? So the single chamber that we had that initially Micra or coming from Medtronic was the manufacturer. It has like 4 tines. So essentially those tines go into the septum and they come out, kind of engage and hold held in place. That's correct. Yeah. This AVEIR, it has a coil. So it takes a bite and kind of embeds. You have to turn it so it embeds in the tissue, and that's how it just stays. And the whole actually system, the idea is to be able to replace it. So you have to screw it in the cardiac tissue, and 10 years later or 5 years later, whenever you take it out and replace it with a new device, you can unscrew it and put a new one in.
So leave in the base of it?
No, everything comes out.
Oh, okay. All right.
So everything comes out from the heart, and the new device goes in.
Okay.
Yeah.
Yeah, because removing leads is a very complicated process.
So that's the question is, why are we so excited about leadless pacemaker? So if you look at the issues with the pacemaker, there are two main concerns. I mean, there are a lot of complications that can happen, but there are two main concerns that we all worry about. One is the device infection. So the device infection is mostly related to the pocket. So your pocket is not sterile. Something happened, or the patient had an infection, your pocket gets infected. The second issue, or the sets of issues, are related to the leads per se. These leads fracture, these leads stay in the system for 10, 20, 30 years, depending on when do you get these pacemakers. They malfunction, they fracture. If there's bacteremia for other reasons, these leads can get affected. So we're talking about extractions. With the leadless pacemaker, there are no leads and there's no pocket, right? So you're not talking about all the pockets complications go away and all the lead complications go away. And if you look at the data, the infection, it's still a foreign body, but at least, there have been very rare instances of infection. There are case reports, but if you look at all the trial, infection rate essentially is 0.
Yeah.
So we have essentially put it in people with bacteremia, and with the cultures cleared up, and they did okay. So it takes away all the complications of the most of the complications of the transvenous devices.
About how big is it? Can you just
So it's about, I would say the ventricular device is slightly larger. It's about 1.5 inch or so, and the
Okay.
atrial device will be about 1 inch in
Wow.
length. Yeah.
And does any sort of, I know we've talked about microwaves and pacemakers before, but with this one, is there's any electromagnetic interference or anything that patient has to worry about?
So it's going to be it would have same limitation, I would say, or caution that we deal with when we're talking about transvenous pacemakers. So we say if you have a very strong magnet, that's the only thing, because it causes quote unquote mode switching, so it changes the mode. So that's the only thing we talk about.
Yeah, I mean it doesn't stop.
It does not.
It just goes to a different mode.
A different mode, and actually it's a safer mode. It actually is,
just
on the side of the safe caution, it's gonna pace, not stop, but actually pace.
Yeah. I always tell patients it's kind of the out of the box.
That's
setting,
right. That's right. So, but no, other than that, no other issues that have been reported. No.
So, would you still use the single for patients that are like just AFib? You want to just pace them
with dual chamber now. The options are wide open. So now, any indication for dual chamber pacemaker implant, you can essentially use them.
Okay.
There are a couple of limitations. First of all, if the EF is low, you can't really, right now at this point, the work is underway, but we don't have what we call a CRT system or BIV system for leadless pacemaker. But as long as dual chamber are concerned, I mean, you can use any indication. There are two main indications: AV block and sinus node dysfunction. And people with sinus node dysfunction, sometimes we just put atrial device. That's all they need.
Yeah.
Your AV node conduction is okay. You don't even need a ventricular device. So you can essentially put one device in one chamber and don't have to worry about anything else.
Wow. And recovery time is pretty quick.
Yeah. So the best thing is, with the transvenous devices, there are restrictions, and it takes some time to recover. The main restrictions are their weightlifting restrictions, arm movement restrictions, because the lead has to settle and the concern lead dislodgement. Here, most of the time, you go from the femoral vein or the vessel in the groin, that heals up in less than a week. Other than that, there's no cutting, there's no incision. Most of the time, patients won't even know that they have a pacemaker. Wow. So there's essentially no recovery time from all this.
The do the dental antibiotic prophylaxis with dental cleaning? That's what patients would ask.
It's not recommended.
Yeah.
Yeah. So it's not really recommended. So I know it's a foreign body. It's there. So we get a lot of calls about it.
Right.
But if you look at the guideline right now, the data says they don't need anything.
Yeah.
Yeah.
Well, this is fascinating technology. I think this is. This is going to. This potential revolutionize healthcare, because you have diaphragm pacing for obstructive sleep apnea. You have the Inspire device that Dr. Heineman's the expert with.
Right.
You have just the number of possibilities.
The possibilities are there.
Bladder stimulation for people with incontinence.
Absolutely right.
You really, I'm just sitting here thinking of all the stuff that's just fascinating.
Right, and there are a few limitations right now, but I think that's with the time. That's one is the battery life, and so since there are two devices and the atrial device is a bit smaller, the battery for the ventricular device depends on a lot of factors, but roughly I tell people about 7 to 10 years. And it's about 7 years for the atrial. So it's a bit shorter for the atrial device. So I think with time, device is going to become more efficient. But, even after 7 years, the whole system is actually, you can take the old one out and put a new one in. So that's what it's designed for. So I think that's the main, everybody gets concerned. Transvenous devices, the battery life is about 10 to 12 years. Since this is a smaller device and they have to pack everything in it, including the battery is slightly shorter.
Do you think that they'll ever have a time where you can recharge it from the outside?
Yes, it can happen. There are a few cardiac devices that you can do that actually,
really?
But it's not for pacing devices. There's a device used for heart failure that does it, but the FDA does not allow it. And the reason being that, for example, let's say a patient forgot about it. So it becomes a safety concern. So that's why FDA has so far said no for that. The technology is there. That technology is available for other heart failure devices where they they actually keep it for a few hours once a week, and the device charges. So it's certainly possible. But FDA, the main concern is, what if the patient forgets? What if they forget to charge? They don't have a charger with them at that point, and it's a life-saving thing. So that's
That
why
makes sense. I mean, we know studies have shown that people that have touch points with healthcare do live longer and healthier than people that don't.
That's right. That's right.
Even if it's incidental flu shots, you get your blood pressure taken. Oh gosh,
That's right.
So that I can understand that sort of rationale.
Yeah, I mean there are other. I mean there for transvenous devices there was a technology. The old technology, it went away. There were some very few people you'll find have what you call nuclear pacemaker. So it's actually radioactive. The battery life is about 30-40 years in those devices. So I'm sure there are the options. The battery life is going to get better. New technologies will come, but this by itself right now, it's a huge leap forward.
And does the leadless will it set off a metal detector like when they go through airport security?
So they get a card.
Possibly.
That's right. Right. So if you actually they have to present this card, and they actually.
And I'm guessing pretty confident it's radio opaque on the X-ray.
Absolutely, it is.
Yeah.
Absolutely.
Yeah, the first we talked previous about the Watchman procedure.
Yeah, right.
In the very first chest X-ray I looked at, the patient that had it, I was like, "What is that?" Because it looks like just a wad of tinfoil in there,
Yeah, for this you will see two metal pieces, one in slightly higher on the heart, one in the right atrium, one in the RV. But I think it's becoming more and more common in the future.
Yeah, I think this is exciting. Like I said, this is just the entry into where this can go.
Absolutely.
Not just the heart. Dr. Farid, thank you again for joining me. Once again, this is Dr. Talha Farid, cardiologist with St. Luke's Heart Care Clinic. To learn more about heart care services at St. Luke's, visit unipoint.org/CR-Heart. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.